Hey everyone, welcome to Let's Learn Patho. The topic we are going to discuss today is lung cancer. And since it is a long topic, so we will discuss it into two parts. This is part 1 of lung cancer, in which we will talk about the introduction of lung cancer, then its etiology, then lung cancer in never smokers, the classification of lung cancers, and details of squamous cell carcinoma and adenocarcinoma. Starting with the introduction part, lung cancer is most common cause of cancer mortality worldwide. And among lung cancer, more than 95% are carcinomas. That means they arise from epithelia. And since here we are talking about lung, so they will arise from pulmonary epithelial cells. Coming to the etiology of lung cancer, most important etiology is tobacco smoke. Around 80 to 90% of lung cancers are associated with smoking somehow. And there is a linear relationship between smoking and lung cancer, as the frequency of lung cancer is directly proportional to pack of cigarettes smoked per year. See, only 10 to 15% of individuals who smoke will develop lung cancer. Not all the smokers develop lung cancer, which indicates that there should be some other predisposing factor which upon smoking leads to development of lung cancer, and the most important predisposing factor is genetic variation. So, these 10 to 15% smokers have some sort of genetic variation which renders them more susceptible to the development of lung cancer. Let's understand this with an example. Suppose in tobacco smoke we have many types of carcinogens which are present in inactive form, so we call them procarcinogens. These procarcinogens are converted into carcinogen in our body with the help of P450 monooxygenase enzyme. This P450 monooxygenase enzyme shows a high degree of polymorphism in terms of its activity. So the genetic variants who are having high P450 activity will convert more procarcinogens into carcinogen, leading to the development of lung cancer. So they are more susceptible to develop lung cancer. After tobacco smoke, industrial hazards like exposure to asbestos, arsenic, chromium, nickel, vinyl chloride, mustard gas, and high dose of ionizing radiations also increases the risk of lung cancer. Then air pollution. So pollutants like radon gas and other pollutants causes chronic inflammation and repair, and we know that if there is chronic inflammation and repair in some region of our body, then there will be a risk of developing malignancy. So it also increases the risk of lung cancer. Then the fourth etiology is acquired mutations. See, there are plenty of mutations associated with lung cancer, but we cannot remember all of them. So we will focus on the most important ones, like small cell carcinoma is associated with loss of function mutation in TP53 and retinoblastoma gene. And adenocarcinoma is associated with gain of function mutation in EGFR and KRAS mutation. Squamous cell carcinoma is associated with mutations involving TP53 gene, RB gene, and CDK and 2A genes. Then, lung cancer in non-smokers. See, non-smokers can develop lung cancer as a result of passive smoke or second-hand smoke or environmental tobacco smoke. Or they can also develop lung cancer as a result of radon gas present in the air pollution and asbestos exposure, right? So plenty of reasons are again there. Passive smoke or second-hand smoke is basically some other person is smoking and you are inhaling that smoke, then you are also at a risk of developing lung cancer, right? The most of the cancers which happens in non-smokers are of adenocarcinoma type, and it is more commonly seen in women, right? And the associated mutations are EGFR mutation most commonly, then T53 mutation is also seen, but it is less common, and KRAS mutation is almost never seen. Then now let's talk about classification of lung cancer. So lung cancer is classified according to the histology into squamous cell carcinoma, adenocarcinoma, neuroendocrine tumors, and large cell carcinoma. Neuroendocrine tumors further includes small cell carcinoma of lung, carcinoid tumors and benign tumorlet. In this video, we'll talk about squamous cell carcinoma and adenocarcinoma only. Starting with the squamous cell carcinoma. Squamous cell carcinoma is most commonly associated with smoking. It involves the central or hilar region of lung. And most common mutation we have already studied is T53 gene mutation, retinoblastoma gene mutation, and CDKN2A gene mutation. After that, now let's discuss how smoking leads to development of squamous cell carcinoma. See, we have suppose normal respiratory mucosa and it is exposed to smoke. So first of all, there will be goblet cell hyperplasia followed by basal cell hyperplasia, and if the smoking stimulus persists, then that will lead to development of squamous metaplasia. Then there will be squamous dysplasia, carcinoma in situ, and invasive carcinoma. So here in this diagram we can see then that there will be goblet cell hyperplasia, then basal cell hyperplasia, squamous metaplasia, squamous dysplasia, carcinoma in situ, and invasive carcinoma. This squamous dysplasia and carcinoma in situ are pre-invasive lesions of squamous cell carcinoma. Coming to morphology of squamous cell carcinoma, if it is well differentiated squamous cell carcinoma, you can see keratin pearl or intercellular bridging. Like this is the slide of well differentiated squamous cell carcinoma, and here we can see keratin pearl, right? But if the squamous cell carcinoma is poorly differentiated, no keratin pearl or intercellular bridging is observed. So these type of squamous cell carcinomas are diagnosed on the basis of immunohistochemistry. So on immunohistochemistry, they are cytokeratin positive, P40 positive, and P63 positive. Then the sputum specimen can also be used for the cytologic diagnosis of lung cancer. For example, this is the sputum culture of squamous cell carcinoma, which is showing orange staining keratinized cell with prominent hyperchromatic nucleus. Now coming to adenocarcinoma, it is comparatively less associated with smoking as compared to other lung cancers. So it is most common type of lung cancer in women and in never smokers. The most common malignancy associated with asbestos is adenocarcinoma, and the most specific malignancy associated with asbestos is small cell carcinoma of lung. Adenocarcinoma involves peripheral region of lung, and the mutations seen here are EGFR and KRAS mutations. Now pre-invasive lesions seen in case of adenocarcinoma are atypical adenomatous hyperplasia and adenocarcinoma in situ. Now atypical adenomatous hyperplasia, the lesions are less than or equal to 5 mm, and the dysplastic cells line the alveolar wall. Then here you can see in this diagram, this is the normal region of lung having simple squamous epithelia, while this region, the alveolar wall, is lined by cuboidal cells. This is the diagram of atypical adenomatous hyperplasia. While in adenocarcinoma in situ, which is also known as bronchoalveolar carcinoma, the lesion size is less than 3 mm, and the dysplastic cells grow along the alveolar septa. For example, if this is the alveolar septa, the dysplastic cells grow along this, giving butterfly sitting on a fence appearance, which is called as lepidic pattern of growth. So this is the diagram of adenocarcinoma in situ, where you can see on the alveolar septa, the dysplastic cells grow, giving rise to butterfly sitting on a fence appearance. On microscopy, if the adenocarcinoma is well differentiated, there you can see the glands which are lined by tumor cells, right? And if poorly differentiated, then you can do immunohistochemistry to diagnose adenocarcinoma, and on immunohistochemistry it should be positive for thyroid transcription factor 1, napsin A, and cytokeratin 7, and it should be negative for cytokeratin 20.